lady probably who is being honored today in Ali Memorial Lecture, prestigious Ali Memorial Lecture.
Just check.
Sure, we are highly proud of you,
Thank you so much.
and all the time we hope you will be beside Bangladesh.
Always, always.
Always. Okay, thank you.
Second home to me, always.
Now it is 10:30. If you permit us, we will start this session.
Surely, sir.
10:30. Google time 10:30.
Did you got a person to say start the session?
Yeah.
But now the president. So
Recording in progress.
Yes. Thank you very much, Professor Namrata Sharma, Professor Abha Hussain, who is the president of Asia Pacific Academy of Ophthalmology. Here we are with Professor Dr. Nujhat Chaudhary, Professor Mustaq Ahmed, Professor Abdul Kader, Professor Deepak Kumar Nag. I welcome all of the ophthalmologists who are attending this session at the 48th National Annual Conference of Ophthalmological Society of Bangladesh, which is being held both virtually and physically. I think I welcome all of you, and today in this session, Professor Deepak Kumar Nag will and Dr. Mustaq Ahmed, they will organize this session, and first of all, welcome speech by Dr. Mustaq Ahmed, and I think we can start now because it is 10:30. Again, I welcome you. Thank you.
Thank you, Dr. Mustaq Hussain, for giving me this honor of reading out the life sketch of Dr. Alim Chaudhary. I'd like to share the screen, please. Dr. Alim Chaudhary was born in a respectable Muslim family in 1938 in Kolkata. He passed matriculation in 1945 from Ishaka High School and passed ISC examination from Islamia College, Calcutta in 1948. He entered the...
Nujhat, screen share. Share your screen.
Sir, screen share করেছি sir.
Not yet. Not yet shared.
এখন হচ্ছে স্যার?
না।
স্ক্রিন শেয়ার হচ্ছে না স্যার?
আচ্ছা, বন্ধ করে আবার শুরু করো।
ওকে স্যার। স্যার
আইটি কই? তাহলে আমাদের এখান থেকে করে দাও। আমাদের
আমি তো সকালেই এটা
আচ্ছা শেয়ার হচ্ছে না।
তাহলে আমি তাহলে এটা পড়ে চাই।
আবার শেয়ার করুন।
আমি খালি পড়ে যাইতে ভিডিওটা
Please continue your speech. Please continue your speech.
Salim Chaudhary was born in a respectable Muslim family in 1928 in Kharagpur, Kishoreganj. He passed matriculation in 1945 from Kishoreganj High School and passed RSC from Islamia College, Calcutta in 1948. He entered the Dhaka Medical College the same year and started to take part in all the progressive student movements in the day. Salim Chaudhary was a socially conscious, politically active, and culturally refined multi-talented personality. And those qualities were evident from very early in his schooling days in medical college. He used to work as sub-editor during the at the life. From the third year of his medical college, he edited monthly literary paper Jump. At the same time, he was also the editor of another literary paper, Khachara. His political ideology stemmed from his dedication for the downward reflective feminism society. In 1952, students of the Dhaka Medical College were at the forefront of our land movement. At that time, he was the vice president of Dhaka Medical College Students Union, who took part in that movement actively. In 1954, he was taken into custody by the Pakistan government on the anniversary of the language movement for his political activism. Dr. Chaudhary graduated from the medical college in 1965 and went on to UK for higher studies in 1958. During this period, he was a joint secretary of EDEM, East Pakistan Medical Institute, and editor of Historian. He obtained his diploma in ophthalmology from London in 1961 and worked in Moorfields Eye Hospital, London, Royal Eye and Ear Hospital, Bradford, Whitehorse Hospital, London, and St. James Hospital, London. While in London, he founded the London-based Bangla Academy, along with a few other expatriates. In 1963, Dr. Alim Chaudhary came back home and joined the eye department of Punabini Hospital in Mizaffarpur as chief ophthalmic surgeon. Subsequently, he worked as associate professor of ophthalmology in the Institute of Postgraduate Medicine and Research, which is now Bangabandhu Medical University, and he also worked in Dhaka Medical College, Sarsoiwanda Medical College. He was also the Secretary General of Ophthalmological Society of East Pakistan and Secretary General of Ophthalmological Society of Pakistan. Dr. Chaudhary was associated with various social and political organizations, doing selfless social work for the poor and the needy. During the War of Liberation in 1971, he strengthened became an underground meeting place for the political leaders and freedom fighters, and his clinic provided shelter and treatment for the injured in the fight. He worked tirelessly to collect money and medicine for the freedom fighters and supply these to their injured conduct. On the 15th of December 1971, his noble doctor was kidnapped and brutally murdered by the Al-Badi, the fanatical collaborators of the Pakistani army. So his Italian church left behind his wife and his daughters, Dr. Farzana Chaudhary, and I'm Professor Ismail, and vouched for his doctor. Few of us can write about the finality of humanity. By virtue of his service to humanity and sacrifice for his country, Shahid Dr. Alim Chaudhary has etched his memory in the country's history. Future generations will look up to him with respect and gratitude, and generations of ophthalmologists will aspire to be like him, a dedicated doctor who made the ultimate success. Thank you very much.
Am I audible?
Yes, yes.
প্রথম থেকে এটা একটু ফেলে দাও তো। প্রথম থেকে sir, I am starting from beginning because of my sound was not clear, defective technical problem. Professor Normata Sharma, Professor of Ophthalmology, Cornea, Cataract and Refractive Surgery Services, Dr. Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences. Dr. Normata Sharma did her post-graduation from Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. She did her fellowship from Moorfields Eye Hospital in London. She is the Regional Secretary, Asia Pacific Academy of Ophthalmology. She is the Honorary Secretary General of All India Ophthalmological Society. Her clinical work includes phacoemulsification surgeries, LASIK, PRK, SMILE, and phakic intraocular lenses. Her key areas of interest are phacoemulsification, including DELC, DSEC, DMAC, anterior segment reconstructive procedures, ocular surface surgeries, and keratoprosthesis. Awards and achievements: 2 patent, Natasol and Natamatrix, brand ambassador for the Tear Film and Ocular Surface Society in India, Research Committee member, Asia Pacific Academy of Ophthalmology. She is honored as one of the 100 most influential female figures in ophthalmology in the world, the Power List 2021 by the ophthalmologist. Achievement Award, Asia Pacific Academy of Ophthalmology. Best Video Award by European Society of Cataract and Refractive Surgery. Best Video Award, Royal Australian and New Zealand College of Ophthalmologists. Best Paper Presentation, American Academy of Ophthalmology. International Ophthalmologist Education Award, American Academy of Ophthalmology. Best of Show Awards 6 times by the American Academy of Ophthalmology. National Awards, Cornell Rangasri Medal, All India Ophthalmological Society, A.C. Agarwal Trophy, Delhi Ophthalmological Society, Krishna Swan Singh Award, Delhi Ophthalmological Society, Om Prakash Operation Award, Punjab Ophthalmological Society, Gold Medal, Indian Intraocular Implant and Refractive Surgery, Appreciation Award, Association of Community Ophthalmologists in India, AIMS Inter Excellent Research Award 2 times. She has 526 publications in peer-reviewed journals, 119 book chapters, has authored 17 books, actively involved in teaching of undergraduates as well as postgraduates via various teaching programs, has conducted and coordinated various hands-on training programs. She is the General Secretary, All India Ophthalmological Society, Secretary, Eye Bank Association of India, Chairperson, Scientific Committee of Indian Society of Cornea and Refractive Surgeons, Executive Member of Cornea Society of India, Member of Women Ophthalmic Society and Intraocular Implant and Refractive Society of India, Ex-Secretary of Delhi Ophthalmological Society. Thank you for patience here. Respected audience, now I would like to invite Professor Normata Sharma to deliver today's prestigious Ali Memorial Lecture. She will talk on phacoemulsification in corneal haze.
Thank you so much, Dr. Mohammad Mustaq Ahmed, for that kind introduction. It was really very. It was. I would like to, thank Ophthalmological Society of Bangladesh for having me give this honor and this oration. I am completely overwhelmed and absolutely touched. I would like to address the dais here, Professor Abha Hussain ma'am, my inspiration, Dr. Sharfuddin Ahmed, President OSB, Dr. Mohammad Abdul Qadir, Secretary General OSB, Dr. Deepak Kumar Nag, Chairman Scientific Committee OSB, Dr. Mohammad Mustaq Ahmed, Member Secretary Scientific Subcommittee OSB, and my very dear friend Dr. Nuzhat Chaudhary. It is an honor and pleasure to be giving this Dr. Alim Chaudhary Award today. And I was very touched by what Dr. Nusrat Chaudhary actually narrated. After hearing the background, I was completely overwhelmed, and it is really uh, nice to know that such people do exist who work not only for themselves like we all do, but work for the society in general. It is a pleasure again and an honor for me to give this lecture, and I would be talking to you about phacoemulsification in corneal case. Now, there are no financial or proprietary interests, and I will be talking to you about off-label use of trypan blue dye and air. And whenever you have a case of cataract as well as cornealoplasty, the bigger question is that whether you should do cataract surgery alone in these cases or combine it with other procedure like a corneal transplantation procedure. So the factors which determine whether you will do a single stage surgery or a combined procedure depend on the type of the corneal haze, location of the haze, expertise of the surgeon, whether you are an expert at SICS or phaco, availability of the donor corneas, and visual requirement in terms of risk-benefit analysis. If the cornealoplasty is paracentral or peripheral like this, one can do a single stage procedure, and if it is central with the anterior layers involved or the posterior layers involved or all the layers involved, one has to then change the procedure accordingly. There may be ocular surface problems in a case of cataract, and then you have to address that. The mainstay is the use of lubricants, preferably without preservatives. If there's some inflammation, then that needs to be controlled using loteprednol, 0.5% QID 2 to 4 weeks preoperatively, and topical cyclosporin 0.05% BD for 12 weeks. And this can be used for 6 months to 1 year also. And then punctal occlusion may have to be done. In cases where you have cataract with pterygium, and if the pterygium is small, then one can anatrophic, then one can do it simultaneously, provided that there is no alteration in the keratometry due to the pterygium. If it is a large pterygium which is blocking the pupillary area, then one has to address that. If it contributes to corneal astigmatism of more than 2 diopter or extension more than 2.2 millimeter into the limbus or width more than 5 or total area of more than 6.25 square millimeter, then one has to do pterygium surgery first and wait for 6 to 8 weeks after pterygium surgery and then do phacoemulsification subsequently later. In cases of Salzburn nodular degeneration, if it is present in the peripheral part, again keratometry has to be done, but if it is present in the central part, then PTK should be done first because some amount of hyperopia would be introduced, and because of the corneal flattening, you may have to change your IOL power. Now, IOL power calculation is a little tricky in these cases. Fellow eye keratometry needs to be done sometimes because of the irregular corneal topography due to epithelial edema or scarring. If you are combining it with a DSEC procedure, then one has to take account of the fact that there will be some amount of hyperopia because of addition of tissue, and so aim for minus 1.25 diopters of myopia, and you may use a standard monofocal lens, and aspheric IOLs are preferred, and generally multifocal intraocular lenses are avoided in such cases. Now, this is the algorithm that we published with cataract surgery with cornealoplasty. It involves a small central cornealoplasty, which is partially covering the visual axis. One can do phaco alone. You may have to do optical iridectomy in some cases, and if only superficial involvement less than 100 microns is there, you may do PTK first, followed by phacoemulsification. But if the involvement is up to 1/3 of the cornea, then you may have to do superficial anterior lamellar keratoplasty with phaco and IOL or SALC triple. If it involves 2/3 cornea, that is up to 70% depth, you may have to do automated lamellar therapeutic keratoplasty or ALTK triple phaco with IOL. If it is cornealoplasty sparing the desmus membrane and endothelium, then you have to do DALC triple. And if it is involving only the endothelium, then you may have to do DSEC or DMEC triple. And if all the layers are involved, then of course you'll have to do penetrating keratoplasty triple. This is our review article, which was published in Journal of Cataract and Refractive Surgery on phaco with coexisting cornealoplasty. And like I said earlier, that we generally use a monofocal lens. Biometry can be done by ultrasound, B scan, or immersion scan. IOL master is often not possible in these cases. And again, keratometry and video keratography may be difficult because of the corneal haze and irregular cornea. So you may have to take standard keratometry for some of the cases. Now, whenever there's a case of fixed dystrophy with cataract and there are no epithelial changes, the corneal thickness is less than 650, cells are more than 1000 cells, you can do phaco alone. If there are no epithelial changes and the corneal thickness is less than 650, cells are less than 800, then one can counsel the patients do sequential phaco with or without endothelial keratoplasty. However, if it is a poor view for phacoemulsification, the corneal thickness is more than 650, cells less than 800, then one has to do a triple procedure. I will be talking about these modifications in the technique which we've already published as I show you the videos. So site of the incision have to be planned. So one half of the cornea should remain clear for us to do phacoemulsification. So for instance, if the corneal opacity is here, then you would do a temporal incision. But if it is located here, then one would do a superior incision. This is a case of limbal stem cell deficiency where Rapan blue staining of the rexes is done. And just as you go underneath that haze which is present there, you tend to go in one go with the help of the capsular rexes forceps because you don't want to lose the edge of the rexes there. And then, of course, you can do your nuclear emulsification as you would do normally. And again, do irrigation aspiration as one would do normally. And subsequently do a foldable intraocular lens implantation. Now, this is a case of Fuchs dystrophy with cataract, and the patient didn't want a corneal transplantation procedure. You can see that there are guttae which are already present here. And in these cases, you can do a phacoemulsification, see how it goes. Only the important thing is that you should always see in the post-operative period, and whenever it is required, one can do endothelial keratoplasty at a later date. But having said that, Viscoat should be used to protect the endothelium throughout the procedure, and BSS plus irrigating fluid should be used so that the endothelial cells don't get compromised. Now, this is a case of healed keratitis, one-eyed patient, other eye phthisis with optical iridectomy, and because the patient had corneal transplantation with infection which went into phthisis in the fellow eye, he did not want corneal transplantation in this eye. So that is why capsular rexes is being done, and you can see that the globe manipulation has to be done. The rexes can be a little eccentric. You can't leave the edge of the rexes underneath that haze, otherwise you will not be able to find it. And eccentric rexes is being done because that is the area the patient is going to see post-operatively. That is also the area which you can see right now. And again, eccentric crater technique is being done here with the help of phacoemulsification probe. And retroillumination should always be on, because as you do phaco in situ, that means you chop, you eat, you chop, you eat. The orange reflex or the red reflex gets better and better. And so these grayish or whitish fragments can be very easily seen camouflaging underneath the white corneal opacity. And sometimes these little fragments may be there underneath this haze, so you have to lollipop them, and then you can see the edge of the rexes here, and foldable intraocular lens is being implanted into the bag. Now, this was a case, in fact, where we did not know that there was a cataract and only pupilloplasty was being planned in this case, and with the help of the cutter vitrectomy probe, the pupil is being enlarged. And as the pupil was enlarged, the zonular cataract was present at the back. So on the table itself, it was decided to do a phacoemulsification surgery. The patient was young, so we didn't have to do a nuclear emulsification, only irrigation aspiration. And notice in these cases, again, the bimanual irrigation aspiration is of utmost importance because you can very nicely go into the fornices and can do the aspiration of the cortical matter followed by lens implantation. Now, sometimes you have a hard cataract, a patient of dry eye, which has been started on topical cyclosporin and Lotepred before, and the pupil is not dilating. So you have to use nylon hooks to increase your area of visualization, do eccentric crater, plan an incision accordingly so that one half is clear, and follow essentially the same principles which I had shown you earlier. Now, this is a case of limbal stem cell deficiency for which corneal surgery has already been done, and the pannus has come back again, obviously because the stem cell deficiency has not been addressed. So you remove the entire pannus from there, and then the cornea looks quite clear. And whenever it gets blurry or hazy, put a blob of viscoelastic. So as soon as you put a blob of viscoelastic, it will get magnified for that split of a second for you to allow you to actually initiate the rhexis and then subsequently do the rhexis, which is stained with the trypan blue dye. Now, this is a black and a white cornea because this was a white cornea. Somebody tattooed this, and this is being done on intraop OCT microscope. You can see that there's synechiae present, which are released. Now, this is followed again by using nylon hooks because the pupil is not dilating. And even in these cases, underneath the intraop OCT microscope, you can see if you lose the rhexis, you can again find it on the intraop OCT microscope underneath the haze. And whenever now you have a third eye, which is your IOCT, which also helps you to see underneath the haze if you miss out something onto the operating microscope. Of course, the steps remain essentially the same. Again, a little bit of eccentric technique is being followed here, and this is followed by aspiration of the cortex. And as soon as you put the intraocular lens, you can see that here beneath this you will not be able to see because of black and white cornea. But as soon as you put the intraocular lens, do irrigation aspiration, the glow gets very good. And then now you want to increase the area of visualization for the patient. So you can do you can use a vitrector to do a vitrectomy. In cases of Stevens-Johnson syndrome, these tips and tricks are also very useful. This is a case, such cases are high risk for keratoplasty. So endoluminator is being used inside to actually chop the nucleus, and one can see where one has to chop. And now it is being used outside to see where the intraocular lens is being implanted. Notice again, the pupil did not dilate, so the nylon hooks have been used to increase the area of visualization and allow phacoemulsification, which can be done properly. This patient was counting fingers at 1 meter, improved to 20, 40 post-operatively. Again, counting fingers, improved to 20, 40. And you can have very tough cases like this, PUK, do a patch graft, white cataract peeping from there, do a cataract surgery. So patient has got a visual acuity finally of 618, not a eagle's vision, but enough for him to be ambulatory. This is again a case, visual acuity improved to 612, here 660, but then again patient becomes ambulatory, and because of the haze, the visual acuity is suboptimal. Now, even the femtosecond cataract surgery is useful in cases of corneal haze, although the laser may not penetrate the area where the haze is present. But it helps you to actually, even if the rhexis, for instance, is not complete in the area of the haze, this is the area of the haze which is there. So one can see underneath this, even if it is not complete, then one can still fill the gaps or fill the bridges by just an initial femtorhexis. This is stained with the trypan blue dye, and wherever it is, wherever there is a gap which is there, that can be, those gaps can be bridged with the help of your capsulorhexis forceps. And then subsequently, the laser energy has already been used, so phaco energy which is used is much less when you do phacoemulsification in these cases, and this is followed by irrigation aspiration. This is yet another case of corneal haze with cataract. Now the corneal haze is present right in the center. So here it is a free floating kind of a capsulorhexis because of the fact that it has cut in the area beyond the corneal haze, and one can still do foldable intraocular lens implantation followed by irrigation aspiration. And this is the third case of flax which is being done in case of corneal haze. So I do believe that again there's a corneal haze there, and there would be a gap which will be present in the rhexis from here to here. So that gap can be actually bridged with the help of the capsulorhexis forceps because it's already cut in this entire circumference here. So it becomes easier to do it. And then subsequently the pre-chops also have been made. They also help to do the case in a much smoother way. This is followed by foldable intraocular lens implantation. Now, combined procedures may be required. For instance, in this case, a case of yield keratitis with spheroidal degeneration. So ALTK is being done. So the 250 microns of the head is being used to remove the area which is hazy, followed by capsulorhexis, nuclear emulsification, just as one would do routinely, except that you have now less corneal tissue which is present there, and whenever it gets blurry, you put this blob of viscoelastic and it will be. This is followed by foldable intraocular lens implantation, and this is the donor cornea with the help of 10-0 monofilament nylon sutures. Now, one can also do this in cases of chemical injuries such as this, and layer by layer dissection is done. Now, you come up to a layer where some amount of stroma is still left. You can't do a phaco with a clear Descemet's membrane. So, some amount of stroma is still left. And then this is followed by the capsulorhexis, which is done, followed by the nuclear emulsification, irrigation, aspiration, just as one would do routinely, and then put a foldable intraocular lens in the bag. And like I said, if it gets blurry, just put viscoelastic. And then the last layer, which is just above the Descemet's membrane, is removed right in the end. And this is followed by suturing of the graft with 10-0 monofilament nylon sutures. This is the post-op picture with visual acuity of 612. Now, this is a case in which 3 rexes were done. So we did epitheliorhexis. This was in fact referred for penetrating keratoplasty. This was followed by the endotheliodesmetorhexis, which was fibrosed in a case of fixed dystrophy, followed by anterior capsulorhexis of the because of phacoemulsification was planned, and then subsequently followed by nuclear emulsification and irrigation aspiration, foldable intraocular lens implantation, and then lenticule which has Descemet's membrane and stroma, and this is then pulled intracamerally inside the anterior chamber, and air bubble is then instilled so that the graft is centered bang on. And this is the post-op picture with the visual acuity of 6-9 parts, and we didn't have to do a full thickness keratoplasty, and this was a sutureless keratoplasty. Then coming to the last bit, which is the most physiological graft, and that is a DMEC roll. Whenever you have cases of fixed dystrophy or you with cataract, then in these cases DMEC can be done. So this is the Descemet's membrane, which has been stained with a trypan blue dye, and this is being stripped all over, come right up to the center on all 4 quadrants, and then lay it on the corneoscleral rim itself. And after laying it, this is dried onto the edges so that the graft sticks to the back of the cornea, and then followed by trephination. And then we stain it with a trypan blue dye again. The peripheral part is removed because it had already been stripped, and this is the Descemet's membrane roll, which is then stripped. And subsequently, this is a case of Fuchs dystrophy, in which cataract surgery has already been done, and foldable intraocular lens has been implanted. So now desmetorhexis is being done, and then subsequently this Descemet's membrane roll is taken and is implanted inside the anterior chamber. Whenever you have this biceps curl upwards configuration, then you know that this is the endothelial side up. So this is the graft which is upside down. So you flip it up because this is absolutely opposite to what it should be. Now it is on the same configuration as it should be, biceps curls upwards, and then air bubble is instilled so that the graft gets stuck to the back of the cornea. So this is on post-op day 1. You can't even make out that a graft was done, and this is at post-op month 1. It just looks as though somebody has done only a phaco. Now, even after several grafts, this was a post-PK DSEC graft because after PK, the cornea had decompensated and the patient was phakic. So again, a cataract surgery is being done in this case after staining with a trypan blue dye, doing a rhexis, and you can actually see the movement of the graft throughout the procedure, what happens to it when you are doing a cataract surgery. So the irrigation aspiration is done. And just as we are doing the last bit after intraocular lens implantation, notice that the graft starts to move. So in the end, one has to instill air bubbles so that the graft gets completely stuck to the back of the cornea. And this is the end of the procedure after doing cataract surgery post PK TSEC case. So to conclude, phacoemulsification and corneal opacity is a challenge, but one needs to plan everything. One needs to plan the incisions. Like I told you, operating microscope should be good. Always remember to put your retro illumination on, because sometimes because of the haze or because of a white cataract, you may not see right in the beginning whether it is on or not. Use nylon hooks, optical aridectomy, trap and loop dye, or endo illuminator. Always use dispersive OVD and good irrigating solution. You may have to use an eccentric crater technique. The fluidic parameter should be low. And in some of the cases where the cornea is very hazy and you can't do a corneal transplantation, you should counsel the patient that what we are looking at is only the ambulatory visual acuity. So for all those cases which are high risk for grafts, one should do phacoemulsification first and see how it goes, and one can always do a corneal transplantation procedure later. But for all those cases which have good prognosis for grafts, one can do combined procedures. So thank you very much for your kind attention.
Thank you, madam, for your wonderful presentation and giving for respect audience. Now I invite Professor Dr. Samsudin Ahmed. Thank you.
Thank you very much, Professor Namrata Sharma.
Thank you, sir. Thank you so much for the honor.
Yes, you have delivered an excellent topic on phacoemulsification in haze cornea, corneal haze. I think all of us have some idea about this type of operations, but you have shown us the triple procedure as well as what to do in case of this type of operative microscope should be a good one. There should be retroillumination. What should be our dispersive OVD, and also we should use the low fluid parameter. So all these things are our listening and lesson to all of our ophthalmology. I think today this prestigious Ali Memorial Lecture which you have given, we have already enriched our knowledge through this lecture. You all know that Bangladesh is a good friend of India. Our father of the nation, Bangabandhu Sheikh Mujibur Rahman, who announced this independence. At that time, India, about 10 million people are in India. You helped us a lot. Our Honorable Prime Minister, she was bound to stay in India during after the death of our father of the nation. So, in all respect, we think we are the good friend. We will be everlasting in all sectors. We will be good friend. You have already today made us in such a friendship that in ophthalmology, AIMS and Ophthalmological Society of Bangladesh and my university, Bangabandhu Sheikh Mujib Medical University, will work together. And we will make a collaboration with AIMS and your center, and we will work together.
Surely.
I think, yes, sure, we will work together. And I think that this type of lecture will be able to hear from you physically. And we all should be always praying that when the corona will be off. And after the corona is off, we will see all of us together physically in Bangladesh and also in India. With these few words, again, I thank you for your excellent presentation and excellent lecture of prestigious Ali Memorial Lecture. You all know that Professor Alim Chaudhary was an ophthalmologist and he was also a leader. And today, his daughter, Professor Nujhat Chaudhary, is one of the renowned ophthalmologists of this country. So I think everything will proceed in such a way that we will work together and we will always remember and respect our martyr, this country. Again, I thank you very much. Thank you very much.
Thank you so much. Thank you so much, Dr. Sharfuddin, Dr. Ava Hussain, Dr. Mustaq Ahmed, Dr. Deepak, my good friends, Professor Abdul Qadir, and my very, very dear friend, Dr. Nizat Chaudhary. Thank you so much for this. And it was really, like I said, I was completely overwhelmed by your father's introduction, Nizat, and I salute him. And thank you so much for this. And regarding the collaboration with AIMS, I think we will work. If we can have some kind of a exchange program, or even if we can have people coming from Bangladesh for say a 3-month fellowship or for a 6-month fellowship, we'll just work it out, and I'll fix up a meeting very soon.
I'm really delighted to have with me our OSB President, Professor Sharfuddin Ahmed sir, Secretary Professor Abdul Qadir, Scientific Secretary Mustaq Ahmed, and also special. I am delighted and thanks to our mentor, our guardian, and the legend ophthalmologist in Bangladesh, ex-SHARC President, APO President, Professor Aba Hussain Madam, and also the audience. As you know, Alim Memorial Lecture is the most prestigious lecture and event of our conference. And every year we invite someone who is legendary in the field of ophthalmology from across the world. And they speak some topic which is very important, which is really interesting for all of our ophthalmology. And this year we are really delighted that we have Professor Namrata Sharma with us, and she has chosen a very good topic, and I am really enjoyed her lecture, and for I think like me, all of our audience actually enjoyed her lecture, and also she has given very good insight. As our President, Professor Sharfuddin Ahmed sir say, PECU is a very common surgery which is the bread and butter for all ophthalmologists. But PECU in corneal haze is sometimes disappointing and very, it's a very complicated thing. Most of us, we cannot handle these things. And I think from your lecture, our ophthalmologist will do this PECU surgery and learn many things which will be guided them in their future work smoothly to give their patients better vision in future. I am really glad to thank Professor Namrata Sharma for her, as she took some time for us for preparing this lecture and given time to join our this OSB conference, which is which gives us an excellent opportunity of Bangladeshi ophthalmologists to hear these things. I should thank her again, and also thanks all of our audience who has enjoyed the lecture and participated in this lecture. So with this few words, I would like to thank and conclude this Alim Memorial Lecture event. Thank you very much. Thank you.
Thank you, Namrata. Thank you.
So much, ma'am, for having me, and thank you. It's always a pleasure to be coming to Bangladesh. I look forward to coming physically there to
Yes.
Bangladesh and meeting you all in person. Thank you so
Thank you,
much.
Namrata madam. Thank you for
Okay,
your
thank
kind
you.
words.
So much.
Thank you. Thank you, Namrata madam.
We miss you physically, but
Thank you so much.
I think in very short
Hello,
time
next
we
session,
will be
Thank you, madam. Thank you for your kind words.
Our chief guest, chief guest.
Dr. Deepu Muni, Honorable Minister, Ministry of Education, and Dr. Mudassir Ali sir.
And Professor Abha Hussain.
Recording stopped.
I invite all of them.
Okay.
Okay, thank you, Professor Namrata.
Thank
We
you.
are now leaving,
Thank you.
Professor, and we will see you again. And there will be the inauguration at 12 o'clock. Thank you very much.